far as like going into detail about some of this stuff in the pathophys portion of it, no. All that stuff that we went over yesterday for this lecture, not something that's like on your exam directly, okay? So any pathophys is not your problem for me. I'm doing that so that you understand your mechanisms whenever you read about your mechanisms and where your drugs are working. To give you like a basic overview, okay? All right, so we're gonna continue with this. This is our last lecture that we have. Depending on how far we get today, we may not have to do Thursday. And then you have all of your review sheets, so those will serve as the review sheets. There were questions about the review sheets. So when we're looking at the review sheets, those are very good summaries that if you went through the slide and you can walk yourself through that entire review sheet, you should be okay for the exam. They're like succinct reviews, okay? So I'm not gonna do like a big class review. I will be on leave, but I will have my phone in West Florida to check on this house. But y'all can still text me. You can still, if I need to draw stuff out for you, you can WhatsApp for me to draw stuff for you because I know your exam is on Monday. And then on Monday, I will be in between both classes, okay? Because their exam is also on Monday. So if you have questions, do not wait until the very end if you're waiting on me. Not like I can tell you the answer anyway, but like don't wait until the very last second. If you have a question that you want me to stare at you and go like this and it helps you get the right answer, don't wait until the last second, okay? So please just be aware of that for Monday. I'm gonna be back and forth and we'll have other proctors in here also, but I'll just be jumping around. So depending on again today, and what questions we have. I'm still available for y'all this weekend to go over anything. I will be available during your class time that you have on Thursday. So y'all can move your class up that you have for Thursday if there is one. Let's get started. Ready? If I am going too fast, slow me down, because y'all's faces be looking like, damn, okay? So, I know you feel like that because of the information, but if I'm giving the information to you too fast, or if you don't understand what the information is, let me know. Because I know y'all watch these things back on like 3 times speed. So if I talk that way, so let me know though. Just be like, okay, can you slow down a little bit, okay? So now, looking at our drugs. So yesterday was just background of giving us kind of what we needed to know, right? So how we can look at these drugs and kind of define them and where they're going to be, what is their function, what is their mechanism, how are they helping me against forming a clot when I don't need it or overgrowing a clot, okay? So when we're looking at our first class, we're going to go through these and we're going to look at anticoagulants, we're going to look at antiplatelets, we're going to look at some stuff that will help us. If I did bleed too much, we're going to look at all the things that are dealing with our blood, essentially, in this lecture. So that's why it's kind of long. So when I look at my anticoagulants, hold on, what is happening? How's it doing that? So when I look at my anticoagulants, I have different routes that become a big determinant in which medication you're going to end up treating your patient with. So I have my injectable anticoagulants, and then I have my oral or my direct, and some of these will call them DOACs because they're direct acting. So I try to kind of lay this out so you can see all of your different options that you have to anticoagulate a patient. And then you see you have indirect, direct when we're looking at our injectables, and the same thing for our orals, indirect, indirect. When you're looking at your orals for your direct, those are the ones that I told you yesterday that we call DOACs, or our direct acting oral anticoagulants, okay? So when you hear DOAC, that's what it's talking about, your oral options that you have for your patient that are direct acting, depending on what we're looking at, whether it's on thrombin or whether it's on our 10A direct acting, okay? So when we're looking at this, essentially I could ask you like, hey, which of the following is a DOAC? And then you can just simply pick what a DOAC is. So I want you to be familiar with that because different monitoring parameters are going to come along with these, and we're going to look at that as we go through the slides. So when you're doing this, make sure you're highlighting if there is any type of monitoring, and make sure you're highlighting if there is, what am I injecting myself? Is this oral? like, so that way you can see what your compliance looks like. Because you'll have some people who are gonna come in and they're gonna say like, oh, I don't want to inject myself, or oh, I don't want to have to come in here every month or every 3 months for you to monitor what I'm doing with my meds, okay? So those kind of things are what come into play when we're looking at this. Okay, so when we're looking at our anticoagulants, remember that these are our drugs that are not breaking down a clot, they're preventing further growth and they're preventing the formation of new clots. So if there's something that is already there, this is not doing anything with that. This is preventing it from continuing to grow, and it's going to prevent it from making any new clots. We're not going to have any new clots formed once you start the anticoagulant. But this old stuff that's there, all you're going to do is kind of keep it where it is. So think of these as like thrombolus blockers or thrombi blockers, okay? That's what they're trying to do. But if it's already there, you're just making sure that it doesn't get any bigger or any worse. So that's why I have that kind of underlined, and that they're not going to break down any other clots. Looking at your clinical uses, when you're looking at these, there's different types of thrombi that we would be looking at. So you have your DVTs, VTEs. When we talk about artificial heart valves, if they're artificial, sometimes the body will want to go and attack them more, or like they may try to say like, hey, you're not supposed to be here. Depending on if they are with animal versus like metal, you have different things that can happen that way as well. So just understand any artificial heart valve. When we're talking about AFib, your patients who have protein C and S deficiency, so those patients, remember, protein C and S was like our natural anticoagulant. So if I don't have that available, my blood is thicker, and I'm more likely to be able to form a thrombus. So if I give them an anticoagulant, essentially I'm helping their blood become thinner to not form that thrombus, because I don't want that, right? Because I can stop, instead of me having my good flow, I can go in and I can do this, and then I have issues, right? Because now I've blocked it off, okay? So your protein C and S deficiencies, those are big deals as well. And then prophylactically after a surgery, depending on what type of surgery a patient has, and they're going to be immobile for a very long period of time, we may want to anticoagulate them because we operated on them. Their body may try to go into overdrive, right? Because now they're in this hypercoagulable state because I cut on them. And so they're likely to form a clot, especially if they're not moving around. So that's why you definitely see like knee, hip surgeries, depending on what we do in the foot, you can sometimes also see where we'll prophylactically treat them as well. So right after they're done with surgery, we will put them on an anticoagulant for a specified amount of time. That will vary depending on the surgeon and what type of procedure you're doing with that patient. So before we start a new drug class, you're gonna see this slide every single time. Okay, so essentially what it's looking at is we're looking at warfarin, heparin, direct factor, 10A inhibitors, direct thrombin inhibitors. These are considered your anticoagulants. Then we have our fibrinolytics. So those are the ones that are going to actually say like, I'm going to bust up this clot. And then you have your antiplatelets, which are the ones who are stopping the party, right? They're stopping all of the other platelets from coming together and aggregating, okay? So solidify this in your mind so that you're not getting your platelets, or your antiplatelets, your fibrinolytics, and your anticoagulants mixed up. So again, as I continue to switch through the classes, you're going to see this pop up every single time, okay? As like a filler slide so you can remember where you're at and what we're looking at. So first drug that we're going to talk about is warfarin. When we look at warfarin, one of our older drugs that we have, still a drug that is popular. We like to use our DOACs more, but some of our patients who are stable and who have certain conditions, we may keep them on our warfarin. So looking at this, you see that it hits several different parts of the pathway, and the way that you can remember warfarin, because it hits 2, 7, 9, and 10. So 2 plus 7 equals 9, and then after 9 comes 10. It's kind of how you remember what it's hitting, okay? Again, lots of monitoring comes with warfarin, but it's a good drug. It's still a good drug. It's just an old drug, okay? So when we look at warfarin, initially they were using it as bait to kill rats. and now we take it to anticoagulate our patient. Okay? Our mechanism, inhibiting that vitamin K. And when we're looking at that, your hepatic synthesis of the clotting factors, we need that vitamin K. It's a part of the B4 complex. And so if I inhibit that, I'm going to decrease the amount of clotting that I have. Okay? And that is what is helping kind of thin out that blood. So when you look at your vitamin K and you're reducing those vitamin K stores, you're kind of deactivating or decreasing the activity of your 2, 7, 9, and 10 cofactors, which are then going to decrease the amount of clotting that you have. Okay? And then remember, when we're looking at that endogenous anticoagulant properties of CNS, so understand that as these are decreasing, and one of the big things that we watch out for with warfarin is that this can precipitate clotting because you're decreasing CNS as well. And remember, CNS were my natural anticoagulants that I had. So if I decrease those, I'm now putting that person in a hypercoagulable state while we initially start our warfarin. So that's a big thing that you're going to see. So sometimes what we'll do is we'll usually bridge when we put our patients on warfarin for about 5 days. Some people do a little bit longer because they're wanting to be safe versus rather safe than sorry. And so you'll see where sometimes, most of the time, we'll try to bridge our patients to make sure that they're still anticoagulated properly in those situations. So just make sure you're understanding kind of what's going on, and that's why we went over that little background again to give you an idea of what's happening. So remember your mechanism of action. Clinical uses. So looking at this drug, the way that I kind of remember it and the way that we typically see it is going to be prophylaxis or treatment of our DVD, PE, and any type of thrombi that we could have that's caused by AFib or a prosthetic valve. We'll get a little bit more into AFib, but just think about AFib as like their heart isn't beating how it normally should. So whenever I have that squeeze to eject the blood out of the left ventricle, it may not get out all the way, and there's like a little appendage that's kind of sitting on your left ventricle, and sometimes the blood will stay there. Even if I'm staying in my left ventricle and I'm starting to pull because I'm not getting squeezed out, right, because I don't have a sufficient squeeze, that blood that stays in there and continues to stay in there can start to form a thrombus. And then when we put them back into normal sinus rhythm, which is what we try to do in our patients who have AFib, they can throw that clot. So that's what we're saying when like somebody throws a clot. So that's why you see us using it here in those patients, because if we're thinking like, okay, I'm about to try to put my person back in normal sinus rhythm, but I want to make sure that they're anticoagulated first so that I'm not like causing any more issues. And you'll do exams prior to you putting them back into regular rhythm because we don't want them to throw that thrombus if they do have one. So that's kind of how we're using it. Your secondary prevention, when we're talking about like somebody who can have multiple MIs, strokes, things like that, just we're using these to make sure that we are preventing the thrombus from progressing to something that's more serious, okay? And then again, in our patients with those CNS deficiencies, because they're going to be, we're going to be thinning out their blood for them. So if they don't have that already, right, we're trying to help them be able to do that because I'm deficient in that natural anticoagulant. I don't have it, all right? So when we also, what I want to make sure of, because we haven't seen this a lot and we're going to start seeing this a lot, where you see secondary prevention, bless you. When you see secondary prevention, essentially what that's saying is like this disease has already happened to that patient before, right? They had it and now we're trying to prevent a second occurrence of whatever that disease is. We're going to see this a lot in the next block, so I'm trying to make sure that I tell y'all whenever I see little things that keep popping up. Okay, so secondary prevention, I've already had this happen to me. So I already had some type of thromboembolic event, MI, something like that, and I don't want this to happen again. This is kind of helping me, especially if that was the underlying cause for me having that event. Okay, so our doses. Typically, we may start with 5 milligrams when we're doing warfarin. Does not mean that that is where everybody stays. That does not mean that it is always the appropriate thing for your patient. Every single patient is going to respond differently, and typically these doses are going to vary widely. okay? So it's not like one of those things where you can be like, I'm just gonna give everybody this. It's kind of like how you think about insulin, where it's individualized to that patient and what they need. So what you're doing whenever you start this is, most of the time we'll put our patients on 5 and we'll bring them back, or they'll sometimes be in the hospital because they had some type of event, and then we're monitoring their INR and we're trying to see what's going on with their INR to say, hey, is this dose too high or too low? Our INR goal is going to be based off of whatever type of disease that patient has. We may have a different INR, so some of them may be 2 to 3, and then some of them you'll have from 3 to 4, like it can vary, okay, as to what your INR goal is. So when we're looking at this, you wait, and then it's like about a week before you're doing, before you're getting and monitoring your INR. The reason why is because remember when we talked about that first 5 days, we try to bridge because they're hypercoagulable. So we want to give warfarin enough time to deplete those vitamin K stores for us to see what it's actually doing in that patient's body. So you have to wait some time for those clotting factors to go down because our body naturally has them, and now I'm trying to deplete them, okay? So that's why you see like it takes a little bit of time. So when you initially put somebody on it, their INR is not going to be what you are going to see. Like it hasn't reached its maximal effect at that point. So that's why you see us looking at about a week. And then with this initial dosing and how quickly we can change it. So if your patient is in the hospital, which is again usually where you're going to initiate this, we will change this dose sometimes every 2 to 5 days, depending on the provider. On the side it says every 2 to 3 days. So again, depending on what your goal is, depending on what that disease state is, you will see that this fluctuates. You will see that some of your cardiology providers will do several neat things when it comes to adjusting and doing dosage adjustments, okay? So looking at your renal dosing, okay, what we're doing in this situation is, if my renal function changes, it is a potential that my INR is going to change, okay? So if my INR is out of range, then you should be looking to adjust the dose of your medication, of your warfarin, okay? So whatever could potentially come through and damage your renal function, damage those kidneys, you're going to need to likely change your INR, okay? I mean, change your dosing of your warfarin to stay in your goal of your INR, all right? Common adverse reactions. So if somebody is over anticoagulated, which you'll see, and even they don't have to be over anticoagulated. Sometimes this is just what happens. Like you'll have a lot of our elderly patients. One, their skin is already thin, right? So their protection is not as good as we would like to see it. So they'll come in and you'll see like lots of bruises on them. They also may bleed for a longer period of time and have easier bleeding. We shouldn't see this like in abundance. It's not uncommon that they're going to bruise a lot easier when they're taking this medication, right? Because now I've thinned out things and they're not clotting as much as I would typically have seen. So now you can kind of like when they bump into something, they're likely to have a bruise. Very easily likely to have a bruise. So make sure that you're asking them about that, like, hey, how long are these bruises staying there? Is it every single time that you've hit something that you've gotten a bruise? Because then we might need to adjust the dose that we're giving that patient. And then looking at this skin necrosis, this is what we were talking about when we were looking at that first 5 days as to why we're bridging to make sure that they're anticoagulated, because that CNS is going to be decreased, so therefore I get a prothrombotic effect in our patients, okay? And we're also still, remember, giving them this warfarin. So we try to bridge our patient and make sure that they're okay. And then purple toe syndrome. Oh, that looks so bad. So when you're looking at your purple toe syndrome, essentially it's because now I'm moving along some of that cholesterol, and so it's blocking the circulation from their toes. Pregnancy. When we're looking at pregnancy, it will vary, and you will see this used in some of our pregnant patients because of the fact that they may have had a procedure prior to becoming pregnant where they have a mechanical valve. When we talk about mechanical valves, they're very, it is very likely sometimes that our body and our blood cells are going to stick to it because it's a foreign object in our body, right? And so Even when we talked about like antibiotics and treating different things in antibiotics, right? We were like, oh, we need a higher dose because they have a mechanical valve. Same thing applies whenever we're looking at this, is that now that I have this patient who has a mechanical valve, I'm worried about my blood cells sticking to that thing and potentially forming a thrombus, and then it goes off into my body and stops my blood flow somewhere, leads me to have an MI, stroke, or something like that, okay? So that's why you'll only see it used in our pregnant women who have a mechanical valve, because that benefit is outweighing the risk. So the benefit of us anticoagulating her is better than us not doing that, okay? Contraindicated in our women who have had any type of eclampsia, preeclampsia, or if they have a history of abortions. So if they were, or like a miscarriage, if they were a high-risk pregnancy and they were like, oh, well, you could have potentially lost the baby for whatever that reason may be, that's what they're considering like a threatened abortion, or if somebody actually had like a miscarriage, not the abortion like I chose to go and do this kind of thing. They were threatened and they were dead, like not that kind. Okay? I just don't, the wording is weird, threatened abortion. Okay? Looking at our pharmacodynamics, PK, drug interaction. So when we're looking at this, our dynamics was the drug doing what? Our drug to our body, right? Like how is that affecting my body? So we're seeing that we have less clotting factors, so therefore I'm thinning out my blood. Remember that I told you that we were talking about vitamin K, and vitamin K is going to be affected by people who have any type of hepatic disease. Okay, so if I have a hepatic disease, I'm likely to have less of those clotting factors as it is. So that's why you see reduced clotting factor synthesis in our patients with our with our hepatic disease. Your competitive antagonism with vitamin K. So when we talk about warfarin, we're going to go over a slide, the next slide, that looks at their food and what they're eating. If they're eating different foods that have higher levels of vitamin K, we can start to see a lot of issues with our INR, and then our goal is going to shift. So when you put a patient on warfarin, you're trying to tell them to keep a consistent diet. Okay? Eat how you normally eat. We need you to be consistent, because I can change my dose of the warfarin based around what that person is typically doing, but you need them to stay consistent with what they're doing. One day, probably not going to hurt. But if they decide all of a sudden, somebody who is eating, you know, a lot of meat is like, I'm only eating spinach and like green leafy vegetables now, we're going to have a problem with our INR, okay? But if I do that typically, and then you got my INR after that first week, I'm okay, like we can keep shooting and adjusting from there. Warfarin comes in a gazillion different colors, and that's our strength, the strength of the medication. So I'm not going to make you remember all of those either, but just understand we have lots of different doses to where we're not having to necessarily tell our patients to like cut a pill in half. Typically we're going to have a dose that they can take, typically we will have a pill that is in the dose that you need. When we're looking at our PK, the hereditary resistance to oral anticoagulants, I haven't seen that really happen in practice. It is a thing that can happen. I have just never experienced it, because all of our patients who take warfarin, they deal with it perfectly fine. Your PK parameters, looking at the fact that we have several different interactions that can happen. Again, just understand that they're there. I don't need you to know any things with our SIPs. Just inducer, they can be induced and inhibited. Okay, that's all I need you to know there. And then our binding. We talked about this last semester. We're looking at binding. If I have a drug that is bound and is competing with another drug that is bound, I can then have that displacement of my warfarin, which is now a big deal, because my INR is going to be affected, because now I don't have much of my my warfarin bound and it's free. Okay, so we want to make sure that we're watching out for that. And a big drug that can help or kind of displace our warfarin is going to be an NSAID. Be sure that you're watching out for your medications that your patients are taking, right? Because an NSAID is something that they don't need you for. I can go over the counter, I can get it. So you need to make sure that they're not taking this in conjunction with that warfarin on a consistent basis. Again, somebody takes something one time, moderation, like they're okay. But if they're consistently doing this, what you can see is an increased bleed risk, right? Because my NSAIDs are already going to possess that, and now I have my warfarin, which is also increasing my chances of bleeding. Okay, so you have that additive effect. And then looking at all of the different interactions that you have with warfarin. If you see a patient on warfarin, go to Lexidrug and type it in. And type in all the other meds that they're taking to make sure that they're not having an interaction, because it's very likely that it probably does. Okay? But it's a great med. It just has a lot of things that comes along with it. So our food. When we're looking at our food, anything that has a lot of vitamin K in it can also inhibit my anticoagulant effect. So what you'll end up seeing is that your INR is going to be affected by that. So you see a lot of this is like our green leafy vegetables. So what you want them to do is, if this is how someone typically eats, that is perfectly fine. You're adjusting your dose of warfarin, okay? But if they don't typically eat that way and they all of a sudden are like, yep, I'm just sticking to green leafy vegetables, look at their dose. You're going to have to alter their dose, bless you, because it is definitely going to affect their INR, right? So just make sure that you're looking at that, because you're inhibiting that anticoagulant effect that you are getting from your warfarin, right? So when we look at this anticoagulation and understanding that it's not something that's necessarily reflective of the half-life of the drug, it's more so reflective on how it's going to stop those clotting factors, right? How it's going to deplenish my vitamin K that I need to make that thrombi to help form that clot. So that's why we were talking about it taking at least 2 to 7 days, and while we're looking at that INR, we're not adjusting our dose until at least 2 to 3 days have passed. But typically, you're wanting to wait a full week to kind of see what that warfarin is doing for that patient, because that's when all of those different factors get affected and your vitamin K stores are going to be depleted. If you need quick, which typically when we're putting somebody on these, especially on warfarin, we kind of have time. We know that there's some underlying disease, that DVT, whatever we're looking for, or that we found, that we have time. If you need to, and most of the time when we start warfarin, we do, because those first 5 days we're worried about that hypercoagulability because of our CNS, we will bridge a patient. Okay, so what you see here is we will give heparin, or we will give low molecular weight heparin to bridge for that person to be anticoagulated until I can get my warfarin where I should expect to see it. I can get that INR taken care of with just my warfarin, okay? Because it's taking some time for warfarin. Warfarin is slow, all right? So up to 7 days, 2 to 7 days, and I can bridge it with my heparin, whether that's unfractionated heparin or my low molecular weight heparin. I'm typically bridging because I may not have a full anticoagulant effect in that first week, okay? We already kind of talked about this cascade. I don't need you to remember the half-lives of when it takes for those factors to be depleted. You may have to remember it somewhere else. I just want you to remember 5 to 7 days is how long it's going to take for you to get to that steady state, but it's not necessarily looking at the half-life of the drug, so to speak. We're looking at how long it's taking for us to kind of deplete or kill off these factors, these clotting factors. When we're looking at our monitoring, I kept telling you about INR, right? And how we're trying to target our dose to a specific INR. Remember when we're saying that somebody has a higher INR, that means that it's taking them a longer time to clot, so they're bleeding for a longer period of time. So when we're looking at our INR, we're measuring this every 4 to 6 weeks, and that's why we have those Coumadin clinics or the warfarin clinics that you'll hear about, because we're consistently monitoring to make sure that we haven't thinned them out too much, that they're not bleeding too much. Also, if I have a person who has an injury, which sometimes we'll tell our patients who are on warfarin, like, hey, don't shave with a blade, and you try to use like an electronic razor instead, because if they cut themselves, sometimes they're going to bleed for a very, very long period of time. Like simple things that we think about. They get injured, they start bleeding, sometimes it becomes more serious for them because they are thinned out too much and they are not able to form that clot. Especially if they have a disease state where we have a high INR target for them, they're more likely to bleed if something does happen, where their skin or their barrier their endothelium gets damaged. They're going to bleed for a longer period of time. So our normal range, 0.8 to 1.2, don't need you to remember it, I just highlighted it for us to kind of know a normal person, this is what they look like. Whenever I'm having a patient who is on warfarin, I'm going to target them depending on their disease state. So if I'm using it for a prophylaxis for DVT, or if I'm using it to treat an actual, some disease that they have where they are forming thrombi, then I have an INR of 2 to 3. Whereas if I have that artificial valve or my high-risk patient where they're likely to form, I'm going to try to thin them out a little bit more because they're more likely to form a thrombus. So you see their INR goal is a little bit higher than 2.5 to 3.5. I don't need you to remember what disease goes with what INR, just letting you know that like we have those target INRs that we are trying to get to, and those are going to change depending on the disease state. So if you don't remember which one you're using it for, Lexi drug, you pull it up and it will tell you, like, it has all of them listed and it will say, here's your INR goal. And your job is going to be to make sure that that person gets monitored for that INR and that they understand to watch their diet, like what they're doing, be consistent, okay? And then looking at this again, give patients this long speech about if they're bleeding, how long they're bleeding. They need to make sure that they call the doctor if they've been bleeding over a certain amount of time. Like, there's a lot of things that go into this. So you're just trying to help your patient be aware of what it looks like when they're bleeding for too long and too much. And then we're monitoring their INR every 4 to 6 weeks to make sure that we're staying within our range, checking in with our patient. Are you still, your diet still normal? All of those things, okay? So the name of warfarin is I'm trying to make sure that my INR is within range. Initially, we are seeing our patient more than every 4 to 6 weeks. That 4 to 6 weeks is for your patients after they have been stabilized, okay? Because remember, I'm going to check on them in 2 to 3 days. You're going to be monitoring them every day while you're putting them on it anyway, typically because they're in the hospital. But within that first week, they definitely need to come back because you should be looking at their INR in that week, right? So this 4 to 6 weeks is your stable patient, okay? Not your new patient that you have on there. So what happens when my INR is too high, right? I'm going to be bleeding, I'm above whatever my range is, I'm out of my goal range. You put me on a med and I decided that I wanted to just eat green leafy vegetables, and I've messed up my INR and I'm doing all the things, and so now you're like, okay, what do I need to do to adjust? How is my patient presenting now? So when you see an INR that is above their therapeutic range but it's still less than 4.5, because remember, the higher my INR is, the more likely I am to bleed. So if you see that they are above their range, but there's no actual, like, I don't see them bleeding from anywhere, their gums aren't bleeding, they're not leaking blood from any like sores or anything that they have, I'm going to hold my dose and potentially adjust the dose depending on why they ended up getting out of range, right? So I'm just going to tell them, don't take your medication. You will have a protocol most of the time at your institution that you're going to be at that will tell you how you're going to hold it. Am I holding it for a day? Am I holding it for 2 days? When am I going to give this back to them? Am I starting them back on that normal dose? They're going to have that protocol for you. If you don't know, or if you do not have a protocol, which you should, contact cardiology for them to help you fix that, okay? Because that goes into a lot of nuances. But essentially, you will hold that dose for them. I've seen a day, I've seen 3 days, it's varied. And if there's no real reason, like if it's not very high out of their 4.5, like over that, if it's over their range but not like by a whole bunch, we typically won't adjust the dose. We'll put them back on it and monitor them again to see if it happens again. Because if it doesn't, maybe it was just like that one day where they had that one meal, or they got stuck on salads for a couple of days, and that's what happened, okay? It doesn't mean all the time dose adjust. When you see your 4.5 to 10 of your INR, that's where you're going to start to see more of us holding back for several days, for multiple days at a time. Again, I have seen this vary, depends on when that patient falls back into their therapeutic range. And then again, you're going to have to snoop and figure out, hey, what happened in this situation? Why did this patient end up this high? Okay, so when you see the 4 to 5, hold the dose, and you can give vitamin K if they are bleeding. All right. You can supplement. You can also do surgery if you don't know why they're bleeding or where they are bleeding from, or if they had some type of injury and now they're not stopping the bleed. You can do surgery to figure out also what's going on as well. So that's where you see this this manipulation essentially of how you're going to be giving the warfarin. If their INR is over 10, you're going to hold and you're going to give vitamin K regardless of if you see any signs of bleeding. So your 4.5 to 10 was like you needed to see if they were bleeding. If they were bleeding, that's whenever we were using the vitamin K. But if you're over 10, you're giving that vitamin K because they're over 10. It doesn't matter if they're bleeding or not. I need the anticoagulant effect from my vitamin K. Okay? And then if you see down here at the very bottom that warfarin-associated major bleed, with this, what you'll see is we give PCC plus the vitamin K to help stop. We like the PCC over your fresh frozen plasma, but you will see sometimes where if that's all you have, you're going to give it, okay? But most of the time at all of our institutions, we typically will see that we have the PCC available for us, okay? So PCC and vitamin K is if that person is experiencing a major bleed. If you have a question about it on the exam, I will tell you they're having a major bleed. I don't need you to figure out if it's a major bleed. And then when we're looking at our INR that's over 10, vitamin K no matter what. If I'm 4.5 to 10, vitamin K if you see the bleed and you're going to hold my warfarin. All of these were holding the warfarin, right? Because they're bleeding, potentially. Okay, we can make them bleed. They're over their goal. All right, and then if I'm less than 4.5, then you're just holding my dose until I can fall back into range, figuring out what happened. Always figure out what happened. Okay, so the vitamin K that we're talking about giving, it comes in 2 different formulations. You see that we have IV, we have PO. Depends on where you are as to which one some people may prefer. If it is a situation where somebody is bleeding, most of the time we're automatically going to try to go to our IV. Make sure that you're looking at your vitamin K, and it's a must is when my INR was over what? 10, or if I have a major bleed, right? That's whenever I'm looking at that. And when I have my major bleed, I'm using my PCC or my frozen plasma. Okay? PCC, we like that one better, right? But if that's all I have is my fresh frozen plasma, I gotta use my fresh frozen plasma. Just know that it's gonna probably take a longer period of time, likely for your patient to have an allergic reaction to it also, but it is an option instead of letting them bleed out. So here, my clinical use is essentially, I'm trying to reverse what my warfarin did, okay? So I'm providing that vitamin K so that my clotting factors can use that to try to start clotting, okay? So I'm replenishing the vitamin K that my warfarin corrected too much, okay? It depleted it too much. Don't worry about this administration part of it. Just understand that when you are infusing, you have to infuse very slowly because if you don't, you get a lot of different reactions. One of the biggest reactions being an anaphylactic reaction, so slow infusion is better. And again, your options that you have, PO and IV, you have less variability when it's coming to the PO, but depending on how bad the situation is, some of our providers will want to go ahead and do the IV infusion. Okay, heparin. Heparin is another one of our older medications. This one, when we're looking at it though, is going to be an injectable. So our warfarin and our heparin, old, okay, they're older, but they are still good medications. Just we now have DOACs and we're after brand new, so warfarin and heparin, okay? Okay, so when we look at our heparin, essentially what you're trying to, I guess I can show you this here. When you see this antithrombin 3 is inhibiting your 10A and your 2A, think of this as a boost. This will help you try to remember our mechanism of action whenever we're going to talk about us using our heparins, okay? So it'll make sense when we go to all the words, but I like to try to go in my brain to a picture sometimes. So that's why, remember your antithrombin 3. So when we're looking at this, just think of your heparin is boosting your anticoagulant effects of your antithrombin 3, is essentially what it's doing, okay? Sub-Q IV formulations that are available, And essentially I want to have a quicker onset, so that's why we were talking about if I had my warfarin, and I was worried about that hypercoagulable state, or if I was needing some anticoagulation immediately, I can turn on my heparin, I can give my patient heparin, and I'm expected to see that work almost immediately, okay? So that's why we see typically our warfarin is going to be bridged with our heparin, okay? Our heparin works a lot faster than our warfarin, and our heparin is working on our antithrombin 3, okay? PK, we already talked about that, sub-Q IV, and then when you look at the different kinds that you have, our low molecular weight heparin is going to be cheaper, one of our cheaper options that we have, but it's still going to be an injection that we're going to be using. Not bound, like we talked about with our warfarin, to those proteins, our plasma proteins, so therefore I have less variability, less interactions that I'm worrying about. And then because of that quick action, I have quick on, quick off sometimes, okay? So several administrations are going to have to be given to your patients whenever you're looking at using this. When we're looking at our clinical use, same things that we talked about. So you'll see this used in STEMI, NSTEMI, VTE, DVTs, PEs. We use this a lot, okay? You're going to see this a lot, especially when we're doing things like surgeries, we'll use this quite a bit. So this is just showing you again that boost that it has and how it's using that antithrombin 3, and then you see your factor 10x in here as well. So just understand picture of your mechanism of action. This is showing you your unfractionated heparin, or our more old school, and then this is looking at your low molecular weight heparin, and it's essentially what it's saying, right? It's a smaller molecule, low molecular weight, but it's still heparin, okay? So still the same ideas going into it. Different size, this is older, this is newer. So in looking at your heparin, unfractionated heparin, again, our adverse effects that we're worried about, bleeding is a big thing, okay? So we're always going to be worried about bleeding. Your thrombocytopenia or your low platelet count. You need to make sure that while you have your patient, if they are in the hospital and they're getting an IV, even if we're going in and you're giving them injections, because sometimes we'll go in and we'll inject our patients while they're in the hospital with the heparin, which is typically what we see. You need to be very careful because they can develop HIT, which is our heparin-induced thrombocytopenia. All right. This is essentially like their body is having an immune response or immune reaction to that heparin. And it can be very, very dangerous for your patient. So we have two different types of HIT. We have type 1 and we have type 2. Type 1 is more common than type 2, and typically like it happens a little bit faster. But essentially 5 to 7 days, you see that like when they're treated with this unfractionated heparin for that 5 to 7 days, you can see where they end up developing HIT. A very serious thing. So please, if you see this happen, the other big job that you have is to make sure that it's documented in their profile that they have this, so that the next provider who comes behind you, if they're trying to use heparin, they know that they can't use it. Okay? So make sure that you're looking at that. Immediately stop giving them heparin. Don't switch them to a low molecular weight heparin because it's still heparin. Okay, don't give them anything with heparin in it and then give them that direct thrombin inhibitor because you're still going to need to inhibit or stop that coagulation factor that you need to anticoagulate them essentially. So that's why we're going to switch them to something else that does not have heparin, so therefore we don't experience that hit. You don't know if this is going to happen, so you're just kind of, sounds bad, but you're just kind of standing by waiting to see if it does happen. If someone has a history of it, don't give it. You know you're going to have to automatically go to a direct 10A. But if they don't have a history, just watch their cell lines. It's going to tell you if they have HIT or not. Okay. Some other adverse effects when we're using this for a very long period of time, or if you have a very high dose, which you will see in some of your patients, you can see the osteoporosis and the hyperkalemia occur in those patients. But again, most of the time when we're using these now, we like to use them just to bridge or to get that immediate anticoagulant effect. We usually don't leave them on it for too long of a time, typically. This is some of the contraindications. So this is what that hit can kind of appear like. Most of the time, though, it's over their entire body. Okay. So those hemorrhages and stuff that they can get in the skin is essentially like that hypersensitivity. So making sure that our patients aren't sensitive to the medication is what we're trying to worry about. You see the severe hypertension and intracranial hemorrhage, so watching out for our patients who may have some type of brain injury, who might have some type of bleed already occurring. We want to not make that worse. And then this surgery of the brain, spinal cord, or eye. When we talk about this, it's because we can have that little puncture, right, that we did to get into whatever that space was, the brain, the eye, the lumbar, and then they can start bleeding from it, okay? So make sure that they haven't had a recent surgery, recent epidural, something like that, that could cause that, that complication to occur in our patients. When we get out of this, then we'll do our break real quick. Okay, so all I want you to know about this, several different formulations that we have available, high alert medication, so please make sure that when you put in your order for it, that you are ordering the right strength. You see all of these different strengths that are available. In the pharmacy, what we try to do is we try to separate them so it makes our brain think twice about which one we're grabbing off of the shelf. Okay, so we don't typically we'll line up drugs by their generic name in alphabetical order, but when we're having drugs that are high alert, usually we'll put them in like a bin of a different color so that we know hey, I need to pay more attention to this, and then we spread them out. They're not close to each other so that it's more difficult for us to make a mistake. Okay, so for you on your end, you're just trying to make sure, hey, am I ordering the right strength, because there's several different ones. Vial syringes, we use them to flush out lines. So there's several different ways that you can order it. Make sure you're ordering the right thing for for your indication. Okay. And then looking at our dosing, you see here that we have a loading dose that we can use, followed by our maintenance dose, which is that continuous infusion. And we're trying to target it to that APTT of that patient, whatever that goal is that we set for them. Okay? When we're talking about prophylaxis, this is because I had some type of procedure and you're just trying to make sure that I'm anticoagulating. Usually we will give that sub-Q. So that's where you see that standard 5,000 units every 8 to 12 hours that patient is expected to be injected. So we're giving this loading dose. Why do you think we're giving them a loading dose? Why do we typically give loading doses? Get them there faster, right? I want you to get in that therapeutic range faster. I'm trying to make sure that I have you properly anticoagulated. Because if you're not, you have a chance, an increased risk of forming that thrombus that I'm trying to prevent you from forming, right? So please make sure that you're looking at the fact that you have that loading dose followed by their standard maintenance dose. Looking at your monitoring, so we were talking about INRs, now we're looking at specifically monitoring my APTT, okay? Looking at this is specifically looking at your factor 7 and some of our other factors, but just remember, what I want you to remember is we're looking at our APTT, and that you're not going to pull your blood, your lab for this until after at least 6 hours has passed, so that you can get a true reflection of what's happening with their APTT. You pull it any sooner than that 6 hours, it's not going to be a true reflection of what you have going on for your patient, and you're not going to know how you're titrating that dose, okay? So 6 hours is a must that you're waiting before you pull it. Our other monitoring, cell lines, right? Essentially making sure that we're not making our patient bleed internally. And then our pregnancy, we could potentially use this. You'll see it in certain situations with our pregnant patients because I'm trying to quickly coagulate them, anticoagulate them. So we can potentially see it, but as you see, category C, not our favorite. We like to see A or B, but it is a potential for us to use it. Let's take a break, y'all. We're not close. Let's take a break. But if I did have CNS, now it's gone, and you've increased my chances of forming a thrombus. So you're going to bridge me with those two medications for at least that 5 to 7 days, and then you'll take off the heparin, and you'll leave me on the warfarin. So I'll have some type of injection that I'm doing for that first 5 to 7 days, and then I'll just be on my oral warfarin. Okay? So I just wanted to clarify so that we're not getting like the two ideas essentially mixed up. And just remember what my anticoagulants are doing. If I have a CNS deficiency, my blood is thick. If I'm using an anticoagulant, that is to thin my blood for me, okay? So try to remember it that way as well. All right. Are we here? Yes. Okay. So when we're looking at our low molecular weight heparin, just like what we were talking about with our heparin, it's still binding to that anti-thrombin 3 to inactivate our 10A, which eventually will help us kind of prevent the formation of that thrombus, okay? The benefits that we have when we're looking at this is that because we're looking at binding our anti-thrombin 3 to inactivate that 10A, we don't have to worry about our APT time. So we're not worrying about our monitoring the APTT when we're looking at our low molecular weight. So we like that, right? Because I have less monitoring, less responsibility for me. The other thing that you'll see with this is that it's more predictable in what our response is going to be than when we were looking at our heparin. We also like this because we're likely to be able to use this in our pregnant women a lot better. One of the downfalls when we're talking about our low molecular weight, though, is that it costs a little bit more money. So, you know, here for us, that doesn't mean anything. On the outside, it could mean something to a patient, especially if they don't have insurance. So, longer half-life, more predictable for us, but less monitoring that we have to do. A great medication, more likely for us to use this in our pregnant patients. Again, when we're looking at it, good for us to use to try to just reduce any type of thrombus from expanding or forming. Now, here are two drugs that we have. Please note the differences between the two drugs. So you have your enoxaparin or your Lovenox and your dalteparin, which is your fragment. When you're looking at these two, you see that you're using them in prophylaxis and treatment, but for our treatment, we see different things. So our prophylaxis, we're using this if we think that there's some type of PE that may end up being, or some type of, you're preventing a PE from occurring. So essentially a DVT that could evolve into a PE. That's why you would prophylactically be giving this. When you're looking up the doses for this, it is important to look up the indication as to why you are using it. Because your prophylactic treatment is not this, or your prophylactic treatment is not the same as you treating like one of our conditions when you're using it for specifically just treatment. Like a person has a disease and you're treating them versus us prophylactically trying to treat them, your dose is not going to be the same thing. So make sure that you're looking at LexiDrug and you know why you're using it so that you have that specific dose for that patient. So prophylactically, we're trying to avoid a PE, and then when we're looking at our unstable angina, we have prophylaxis with our enoxaparin. We see that we can also use our enoxaparin to treat DVTs. We see that we like to use this for we're trying to bridge, and we also can use this in our patients who have a STEMI. Those are our treatment indications. When you're looking at your treatment for your dalteparin, we have it for our patients who have VTEs, okay? So, and specifically looking at our cancer patients. So the one that we are typically using is going to be your enoxaparin. Also, we see that our pregnancy category and the drug that we prefer in our patients who are pregnant are going to be either one of these. We typically use enoxaparin because whenever we looked at studies, they have a better anticoagulant effect with enoxaparin versus using the dalteparin, okay? So that is why we typically will see our enoxaparin used in those patients. Already talked to you, so this is like your summary slide. No monitoring that we have, longer half-life, right? So that's why we see that it's more predictable, does cost a little bit more, but it's still a great, great drug, and we like it for our pregnant patients. Enoxaparin is the one that you're more likely to see, but you have dalteparin also. Side effects. Looking at this, we have bleeding, of course, like we had with any of our anticoagulants. You're going to always see bleeding with a lot of these drugs that we see. It can cause HIT because it is a low molecular weight heparin. The incidence, though, of it happening is less than if you were using regular heparin. So just please be mindful that you're still not getting away from the fact that it could occur. So your patients who have had a history of it, we are very cautious in using it. I have seen it be done, but they are monitoring the patient very closely. Okay? So just again, your big thing here is that it can cause it lower incidence than it causing hit in your patient who is on heparin. Our protamine, bless you. We were talking about protamine being a reversal agent, but it's not going to reverse the effects of my low molecular weight heparin. So don't think that if you overdose your patient, that you're going to have those same benefits with using protamine in this situation. And then your black box warning. Remember, our black box warnings are things that could like kill us, right? They're very serious side effects that can happen in our patients. So when we're looking at our spinal or epidural hematomas, we're very worried about this in patients where we think that there's going to be some type of spinal or like epidural that we need to do. So you want to wait at least 12 to 24 hours after that last prophylactic shot that you could have potentially given that patient before you would do your tap, before you go in. Because if you don't wait, you're likely to increase their risk of a bleed. If you already are running something and it's in their spine, or like you already have an epidural in, avoid these medications because you can increase their risk of bleeding from that site. Okay? So just being aware that these hematomas can definitely occur in our patients and they can be detrimental to your patient. Okay? Very serious black box warning. Yes?
So why are these preferred for use in pregnancy then? Because when
I'm not having my baby yet. There could be something going on, because remember, so like, you can have a patient, and we've had several patients that were like this, where they're pregnant, and some of them, they will form clots because they have gotten pregnant. Remember, pregnancy is one of those things that can cause a woman to be hypercoagulable. And so I will anticoagulate her while she is pregnant. She is going to have blood thinners that entire time while she's pregnant because I don't want her to throw a clot at any time. So if I had to, for some reason, anticoagulate that pregnant woman and she had like some kind of mechanical valve or whatever, this is where I typically go. I would just pull that treatment prior to whenever she goes into labor. I also have other options that are not necessarily preferred, but that is why we're using it, because it's the safest one that we have in that situation. Yes?
Like extreme bed rest where they have to be immobile, would that be an option there, these drugs?
Yeah, so anytime you have a patient who is immobile, you're likely to do this. Like you're likely to anticoagulate.
Especially in the pregnancy, yeah.
And even in pregnancy, because now I'm even more hypercoagulable because I'm not moving, I'm stagnant, not going anywhere. Also, you'll see this sometimes, like if you do a surgery and the person is going to fly very soon after, we may try to anticoagulate them as well, because we are going to cut on them and they could potentially throw that clot that they formed. Yes?
For the pregnancy, they'll continue to leave you on it. I was on this medication throughout my entire pregnancy. So they'll continue to leave you on it as well if you have a genetic condition.
So, but now I'm just asking, because our person had delivered already and we stopped it before. Did they keep, like when you delivered, did you do an epidural? Sorry if it's too...
I did. It didn't work, but I did. They did
that happened to me too.
They had to take me off the Lovenox. Like I was induced, so I had to be off of it for a certain amount of time before they would induce me.
Okay.
And then I had to be on it for an additional 8 weeks
after. Yeah. Okay. Yeah, my epidural didn't work either. It was great. So this, like, it's a great medication, right? Like, you have several different reasons why somebody may be on it. Hip and knee are not the only times either that you'll see somebody anticoagulated with these. I had surgery on my ankle and I couldn't walk for 2 months. So I was moving, but I had to fly from here back to Fort Bliss right after I had surgery. So I was supposed to inject myself with this. I'm a horrible patient. I did not do it. I was like, I looked at that needle and I said, oh, she's good. Mom, if I die on the flight, you get some money because I can't do it. So, like, See, that's why I tell you to talk to your patients. You're gonna get needs, okay? You're gonna get needs. Make sure that you're just understanding that it's something that they're supposed to do, it's something that they should do, several different reasons why, and I'm sure that they're gonna talk to you guys about like the scope of all of it. But like you see, like I can be pregnant, I'm taking it because you need to anticoagulate me that entire time, but they will have different cutoffs. And some doctors may be more stringent. Yes, the guideline could be like, oh, 12 to 24 hours, but somebody could be like, yeah, I want you off of this for 5 days or whatever. Like they can do whatever they want to do, as long as they hit that bare minimum of what the guideline says. So this big idea with this is like, look at this for as your summary, a quick snapshot of what you're monitoring, or in this situation, what you're not monitoring, and make sure that we don't have anything going on with their spine, or we're going to discontinue this medication prior to. If they have a line already there, we are not going to start this medication until that line has been removed, and we wait a certain time after that as well, before we'll start anticoagulating them as well. Okay, so we won't immediately like do an epidural and then right after we're like, all right, now you're anticoagulated, right? Because I still haven't plugged that up yet. So they typically will wait some time before they start that anticoagulation again. Okay, more about our low molecular weight heparin. When we're looking at this, just understand that you are going to be most of the time giving them their medication based off of the indication that they have, and then you have some times where you can do weight-based dosing. Most of the time what we did in the pharmacy was weight-based because it was more specific to that patient, and because there's not that monitoring that we have with it, at least we knew we were close to what that person should typically be receiving, okay? So you have weight-based when you're talking about your treatment, which is what I typically was dealing with, and then we have for prophylaxis, everybody is typically getting the same thing. It did sometimes vary depending on if you were in the ICU versus if you were just a regular hospitalized patient. So thinking about that. Our admin, sub-Q, they can either have this injection once a day or twice a day. They're not interchangeable, so don't think that like, oh, whatever my treatment dose is also my prophylactic dose. Not the same thing, okay? And then when you're talking about anti-factor 10A, that assay, if you did pull it, it does exist. It is expensive and it's not very accurate. So most of the time you won't see a provider pull it. If you're in an educational area, like if you're here at BAMC, I have seen where they pull it so that they can talk to us about it and be like, see, this is blah, 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 and they'll tell us about the assay and all of that. But like on a regular basis, it's not something that you're typically going to be pulling to monitor the effectiveness of your low molecular weight heparin. Advantages, we already talked about this, right? I don't have to monitor because of that long half-life that I have with this medication. I don't have all that variability. So these are my advantages over my heparin. And then looking at my monitoring, the thing that I've been doing for everything and my adverse effect, is my patient bleeding? Are they bleeding for too long? That is an indication that that dose may be too high for that patient. Pregnant women, we are going to prefer this medication. Doesn't cross the placenta, we like that, right? So that's why you see that good rating of the category B for these meds when we were talking about them. Protamine. So when we're talking about our protamine, remember we said for our unfractionated heparin, we can use this and we should expect to see a reversal if we overdose our patient. With our low molecular weight heparin, we were saying, I may not get a full response. I might get some response, but I might not be able to fully reverse what I did, okay? So don't think that you're gonna get a full reversal if you're using protamine with your low molecular weight heparin. So comes from the fish Pharm, and essentially what it is doing is neutralizing or binding to that heparin very quickly to make it stop anticoagulating. So therefore, you can try to start clotting. Those factors would come back again, okay? Make sure that you are consulting pharmacy if you are not sure about the dose. There should be a protocol that is available for you. And as you see here, 1 milligram is reversing about 100 units of that heparin that you gave that patient. This is not as reliable if we gave them that unfractionated heparin, because we don't have this conversion as solidified, and it's very variable as to what will be reversed, okay? So if I have heparin, I have protamine. If I have low molecular weight heparin, I kind of have protamine to help me reverse it, okay? Looking at this, we already talked about that caution. If somebody is allergic to fish because of it coming from the fish, right? We need to make sure that we don't put them in anaphylactic shock. So now we overdose them, we thinned out their blood too much, and now we also have them having an allergic reaction because we gave them something that's made out of fish. So make sure that you're looking at that when you're looking at your infusion reactions. Especially if you're running it quicker, you're likely to see that flushing occur. Some patients will tell you that they kind of feel like short of breath. We need to reverse, like, I don't want you to bleed internally. So these infusion-related reactions are typically not as concerning unless their blood pressure drops very, very low. Of course, we're worried about it, so slow down your infusion if you can. So that's where we see that sudden drop in blood pressure and bradycardia, because as we know, like, one goes down, the other one can go down. And then your drug interaction with certain antibiotics, especially if you have a person who's on several lines, this kind of comes into play. If they're on a CEP or a penicillin, this medication does not play well, so our reversal agent is not going to play well. So we typically would try to run them in 2 separate lines so that they don't cause or have that interaction in the line. So that's where we're talking about that incompatibility, okay? So make sure we're watching out for that. Fondaparinol or fondaparinox, depending on who you talk to. Mechanism of action, again, that antithrombin 3, which then is going to inhibit our 10A again. So anything when we're talking about antithrombin 3, most of the time is going to inhibit our 10A, so therefore we're slowing down or preventing that clotting. So we're still getting the same result where we're thinning out the blood. Our clinical uses are starting to look very repetitive and familiar. So prophylactically, we can use it in our patients who to prevent a DVT. So again, when we have ortho orders this quite a bit, because if I am doing a hip, a knee type of surgery, I'm likely to see that my patient is going to be probably more immobile than somebody who I've done something on, like their arm or typically their ankle. Again, the only reason why you would be doing that is, like, let's say I broke both of my legs. I'm not going anywhere. You're going to need to anticoagulate me, right? So that's what ortho is kind of doing whenever they're using some of these medications. Abdominal surgeries, you'll see this also, just trying to thin out things so that they're not becoming hypercoagulable in that area. And then looking at your acute DVT, if you're trying to help with, like you're doing and you're bridging sometimes with that warfarin, you can see that they're using it in conjunction with the warfarin in your acute PE or your pulmonary embolism in your patients. Again, you're using this with warfarin. And this is probably one of our first meds that we would go to in that patient population. So, summary of this, indirect thrombin inhibitor that you have, this is not a low molecular weight heparin, but it's very similar to our low molecular weight heparin. So we had our enoxaparin and our dalteparin that were low molecular weight. Our Fonda is not a low molecular weight, it just looks very similar to it, and it's doing that same action on your antithrombin 3. So don't mix that up. Not a low molecular weight heparin. And then you see your prophy and your treatment of your DVT, and then we have PE treatment in conjunction with our warfarin for those patients. Okay, PE and acute DVT with warfarin. Sub-Q medication, when you're looking at it, we see that we have monitoring not required, so that's why I was telling you this looks real familiar to low molecular weight, but don't like mix it up with low molecular weight heparin. Black box warning, still the same thing. Your adverse effects, still the same things. Less likely to cause HIT because it's not a low molecular weight heparin. So you see this, but we don't know if there's a cross probability of that happening. So that's why we have that it's less likely when we compare it to heparin or our low molecular weight heparin. So this would be even less than our low molecular weight heparin, right? So if we had HIT, we would be like heparin, yes, we could have that. low molecular weight heparin, and the chances drop down. Our Fonda, they drop down even more, okay? So we think that it could potentially be a cross reactivity. Now, the FDA does not say, hey, if someone had HIT to use Fonda. But what a lot of people will do is they will use Fonda because they haven't seen it happen. They haven't had anything that proves that yes, this can cause HIT, but they haven't had anything yet to say that it does it, for sure. So in practice, you're going to see that if somebody has HIT, they're usually going to put them on Fonda. Okay? What lab should we be monitoring during our heparin therapy? Okay. Am I worried about their glucose?
No.
No, not really worried about their glucose. Liver function test. I mean, we're monitoring these things, right? But like, I'm not monitoring them in the sense of my health. Now, my INR, who was I worried about my INR with? What drug was that I was with? Okay. And then my APTT, yes. What about, could I use my anti-factor 10A assay?
Yes.
Yes, but what's wrong with it?
Expensive.
Expensive, and it's not super reliable. So that is another option, but that's not typically what we would be talking about if we were looking at monitoring. For this, if we were looking at monitoring, we would be talking about our APTT. And then, what if I said, what lab should be monitored during our heparin therapy? What would be your answer? I mean, during our low molecular weight heparin. I don't need to monitor that, right? So when you look at this, like go through and make you a chart of saying like, what is my monitoring parameters? What am I looking for? What is my big adverse effect outside of bleeding that I'm worried about whenever I'm looking at a specific anticoagulant? Am I super worried about HIT? Am I minimally worried about HIT? Can I use this in pregnancy? Like, where am I using the medication? Okay, and then use your review that I gave you for this is pretty good. Okay. Okay. Your direct factor 10A inhibitors. So when we look at these are some of our ones that we are also going to talk about that were our DOACs. Okay, so kind of remember DOAC and then hearing that because you're going to hear that a lot whenever you're in phase 2 probably if you're looking at any of these. So our mechanism of action here when we're looking at this, these meds are blocking your 10A directly. So I don't care about anti-thrombin 3, like I don't need any cofactor. I'm going directly to the source. I'm like 10A, I'm blocking you. Okay? So this is a direct 10A inhibitor, direct blocker. And instead of us injecting ourselves, how we had our sub-Q, well not our warfarin, but our sub-Q, now this, I'm not injecting myself when I'm dealing with the 10A. I'm going directly to the source, and I have different options to where I can have oral options. So that's why we said they were oral anticoagulants. Okay? You see that your black box is still the same. All right? If you need to talk to your patient because it is an oral medication now, right? So people feel like the threat is very low and they're likely to miss that dose. Please make them understand that this is something that is very vital for them to not end up forming a thrombus, because if they start to form that thrombus, there's nothing that we can do about that. We would just continue to be preventing it from growing. So we're trying to prevent them from having any new ones if they have any at all. So making sure that they are adherent is a big thing when we're talking about any of these meds. Okay? Any of our anticoagulants are very, very serious because we're trying to prevent something from happening. That's why we're using them for prophylaxis. And if you're treatment, like if we're in a treatment phase, that means I know you have some type of DVT or VTE or some type of propensity to have it. I'm trying to treat you so that we don't have a bigger event. Okay? So adherence is key. Stress to them, even though they don't have symptoms, they may not feel anything wrong, that they need to take this medication, because those are the worst diseases that we have are the ones where people don't see anything wrong and then they have these big events that happen because of it, because they're not taking their meds. My advantages versus my warfarin. So when we talk about inferiority, It's not that it's inferior to warfarin, it's just as good as warfarin. But what we can see here when we're talking about this is, and y'all will get probably more detail into this, I don't know, but like when we talk about heart valves, with this, you're allowed to use these and they're more effective when we're talking about prosthetic valves than when we're comparing it to warfarin. And then the other thing with this is that these cost a little bit more money than warfarin, right? Because they're more convenient, they're newer. I don't have to monitor you. You don't have to come into my warfarin clinic every month for me to check your INR. So these are going to be a little bit more costly than some of our other meds. And then we do have Indexa now that is available, and the way that you can remember that this is an antidote for your direct 10A drugs is that it has XA in the brand name. It also has it in the generic name, recombinant factor 10A. And then Indexa has the X and the A in the brand name also. So this is your antidote to try to reverse if you had overdosed your patient with a DOAC, or if they overdosed themselves with a DOAC. And then we already talked about our, and I said that backwards. We already talked about our disadvantages with the ability to use them. We were saying with our warfarin is prosthetic. I think I said it the other way around. Warfarin is prosthetic. Our DOACs, there's a lot of nuances when we talk about our DOACs, and even the dosing when you're talking about your DOACs. So there may be one dose that I need you to remember about that, but when I see it, I'll let you know, but I don't think I want you to remember the dose. Your black box warning, all that stuff, remember, same thing as what we already saw. So here are our options that we have. So you're saying this is rivaroxaban or Xarelto that you see lots of commercials about, apixaban or your Eliquis, and then your edoxaban or your Subasa. These are your two more common ones that we typically are prescribing, so your rivaroxaban and your apixaban. You see that our indications are listed here, so when we talk about AFib, we'll go over that in the next block. These are very common meds that we're going to use in our patients who have AFib to make sure that we don't, if they do go back into normal sinus rhythm, that they don't throw that clot, so we prevent them from having a stroke. And then the prophylaxis from our DVT in our patients. So as well as PE, you can see the treatment for those as well, those indications. So DVT and PE treatment. Adverse effects, bleeding, we already talked about that. If you are going to administer this with another medication that is going to thin out their blood or stop the formation of a clot, that's going to increase that risk, and that's for all of our meds, not just this one. Good thing with these, remember, we didn't have to monitor them. They're oral medications, so my monitoring isn't required, but I'm always monitoring for all of these meds that we talk about in this lecture. I'm always monitoring for bleeding. And then looking at my warnings or my precautions, make sure that you're watching out for your patients who have liver impairment. You can look at their the drug monograph or look it up on LexiDrug and see like if they have a Q score of C, like can I use this or not, because there's different cutoffs for different ones. But we typically will not see these used in our patients who have hepatic impairment. With your edoxaban or your Subasa, looking at this one, understanding that this one is also worried about their creatinine clearance. So if that creatinine clearance is very low, which is less than 15, make sure that you're going to avoid using this medication. So this is one where we're worried about our creatinine clearance. Watching out for our SIPs, making sure that we're looking at that in your PG protein. Make sure you're looking at that. More so worried about you looking at those SIPs. And just remember SIPs, don't remember which SIP interaction. When we look at our category for pregnancy, we like apixaban better than looking at our Xarelto or our Subasa. And then looking at our warfarin convert. So what this is saying is if I had a patient who was on warfarin and they no longer want to be on warfarin, they're tired of coming into the clinic for monitoring, and they want you to put them on a DOAC, this is how you would switch them from one DOAC to another DOAC. I mean from the warfarin to a DOAC, okay? I don't need you to remember this, I just want you to know that yes, I can take my patient off of warfarin and put them on a DOAC. okay? So when you're doing that, you're waiting for their INR to get in a certain range before you switch them over, is essentially what's happening. They all have different cutoffs. Again, you look this up, okay? So I don't need you to remember the cutoffs, just know that I can, if somebody has been on warfarin, I can put them and switch them to a DOAC, okay? So that's what this is saying. So for instance, if you had to look this up, if I were taking warfarin, I had been on warfarin for years, and I'm like, you know what, doc, I don't want to do this anymore. I'm tired of coming in here every month, or I don't drive anymore. I would like to be put on a DOAC, something that you don't have to monitor. You're going to say, okay, you want to be put on Xarelto? I am going to stop your warfarin, wait until your INR is going to be somewhere less than 3, which depending on what indication, my INR may already be less than 3, and then I can go ahead and I can start taking my Xarelto. Okay? Because remember, my INR target can vary depending on what med I'm on, or what my indication is. All right? Okay, more direct thrombin inhibitors. So when we're looking at this, make sure that you're understanding that our structure the structure of these meds are based off of hirudin, which is coming from like the leech's saliva, which we do have in the pharmacy. We do sometimes, like when people come and they like have cut off fingers, or they have what do they call it, road burn, where like their skin has like come off and you're trying to save things. You guys will order leeches from the pharmacy, and I get very angry because they make us catch them, and we put them in like a container for you guys. Please make sure that when y'all do get the leeches delivered to you, that you close the lid, because I was in a room where this person cut off 3 of their fingers. And so they ordered the leeches from the pharmacy. Somebody was worried about getting the leeches out, and they left the top like just sitting on there, and the leeches pushed the top off, and they were over the floor. And I was like, so I don't think we can use any more leeches because they're on the floor, and I'm not picking them up. And I just like, so then they're all around the floor trying to like find the leeches. So what we said was, cool, leeches can help stop and like prevent some of that clotting that we see. So we made a drug to help inhibit that thrombin as well, okay? So that's where this is coming from. And then we also have to clean the leech tank. And I was like, just buy some new ones and throw the things away. And then they kill them afterwards. It was so sad. I felt bad for the leech, but you can't reuse them. I don't like killing stuff. Okay? Sorry. Kill the leeches. So these drugs are based off of that property, and we saw what we could get out of the leech, so we made a drug that had a similar structure to be able to do the same thing. Okay? So our 2 meds that we have that fall into this category are going to be our bavalorudin and our agachaban. When we look at these, you see that these are IV meds, okay? So our patient is going to be in the hospital with us. Our biggest indication that we're typically using these for are going to be our prophylaxis and our treatment of some of our patients who have HIT, or if they're at a high risk of having HIT, okay? So these are the ones that we can use if they had HIT previously, okay? You see that we can use this for PCIs, right? So remember, if I was looking at my MI patients, my STEMIs, my non-STEMI, and if I had to do a PCI, I can give my patients these medications also to kind of help with our anticoagulant effect that we would typically see. Pharmacokinetics, renal clearance. So when we're looking at our bavalorudin, making sure that creatinine clearance is over 30. Once we start getting below that, you'll see where there's different dosage adjustments that are required. Don't need you to remember what they are. Just know that after below 30, I need to look it up, okay? Because there's going to be a dosage adjustment. It's not going to be my typical dose. Whereas when I'm looking at my ergachaban, I'm worried about if there's any issues with their liver, and I may have to adjust their dose based off of the severity of their liver damage. So see what their Child-Pugh score is, and then you're going to go into Lexidrug and say, all right, if they're A, do I really need to change anything versus if they're more severe? Again, watching out for any bleeding that they may have, and then our monitoring, we have our APTT that we're monitoring in these patients as well. And then their activated clotting time, how long is it taking for them to actually clot? okay? I don't need you to know the cutoffs of like what they are. I just need you to know we're looking at our ACT and our APTT. That's it. Okay? Not what those ranges are. And then this warfarin bridge that you see here, understanding again that I can use this to bridge my patients who are using warfarin. So I'm overlapping those things because remember it takes my 5 to 7 days for my warfarin to work. So if I need some anticoagulant effect, immediately I can also have this as an option for me to use during that time. All right? So make sure that you're remembering also, hey, can I bridge with this? Am I getting an anticoagulant effect quickly because my warfarin is a little slow? The first one that we talked about, the first drug that we looked at, our old drug is behind 5 to 7 days. It needs to catch up. Specifically looking at your dabigatran, direct, looking at that thrombin inhibitor, but what we also see here is that it is a prodrug. So when we're looking at this, it still falls under being a DOAC, right? Because I'm saying that it's direct acting and it's an oral medication, okay? So that lets you qualify it as a DOAC. Inhibiting our thrombin directly, right? So then I see that when I'm looking at my uses, I can use this again for prevention, and I can also use this here for treatment when I'm looking at my DVTs and my PEs. So a lot of these DVT, PE, prophylaxis, and or treatment when we're talking about these meds, okay? When I talk about AFib, I'm always worried about my patients potentially throwing a clot, especially if I choose to cardiovert that patient or get them back into normal sinus rhythm. So that's why I'm usually prophylactically treating these patients. Once I get hit and they're like, oh, you have AFib, most of the time we're gonna put them on some type of anticoagulant medication because again, that blood flow is not, it's not flowing great and we can have an increased risk of clot formation. Looking at your considerations. So when we talk about this drug, you're going to have a lot of elderly patients who are going to need to be anticoagulated. But we have to watch out specifically with these because I can increase the risk of that bleed in that patient, and I'm likely to see that in my patient who is going to be older. So specifically with this one, in our patients who are over the age of 75, we try not to use this medication. Not saying that it is an absolute contraindication or that you won't see a patient who's over the age of 75 on it, especially if they've been on it for years. But it's not something that you'll typically see us starting. Poor renal function, because we were just talking about like our creatinine clearance and looking at that, or patients who are underweight. Sometimes if they're underweight, we'll get more of an anticoagulant effect than what we were trying to get in our patients. So that's why we kind of are more cautious with our patients who are underweight. So think about some of your elderly patients who are very frail as well. This is something that we're very, very concerned with whenever we look at these medications. When you're looking at your indication, I don't need you to remember this, but you see that when we're talking about for our AFib and your treatment and prevention of your DVTs, that we can have different dosing for it to where it can end up being BID versus somebody taking it daily. Just understand that dosing depends on the indication, just like all of these other drugs. My target INR depended on the indication. My dosage for this depends on the indication. And then your black box warning is still the same thing. If they stop taking their medication, they're at an increased risk of having a stroke, the same thing that we already saw. My drug interactions, when I'm looking at this, just think about if you're giving them any other medication that can make them bleed, or if I'm giving them like an antiplatelet. So if I think about like aspirin or clopidogrel, those are also making me to where I'm not forming a clot, so I have an increased risk of bleed. But if you give me like a low dose aspirin, which is what we were typically saying, like our patients who end up with some type of STIMI or in-STIMI, like we're going to end up sending them home when we're talking about our DAP. So if they're on a dose that is less than 100 milligrams, typically we're not concerned, okay? We do want to try to avoid ticagrelor, which is one of those meds that we're going to talk about later, because we can see a higher risk of bleed whenever we're looking at that antiplatelet medication. Also, we have our P-glycoprotein showing up again, so just looking at that and making sure that you understand that if there's anything that inhibits that protein, that our levels are going to go up, which means I'm going to now over anticoagulate my patient. So I do want you to look at those medications to make sure that you're familiar with our P-glycoprotein, because we typically don't see that as much. And then looking at my inducers, that's going to decrease my efficacy of my dabigatran, so I'm more likely to form a clot in that situation. So just paying attention to whether or not I tell you that something is an inducer versus an inhibitor. Specifically looking at that inhibitor, I will tell you, I'll be like, oh, if this is an inhibitor, what is it doing? Okay. What is it doing to my dabigatran levels? What's happening to my risk? Did it increase? Did it decrease? Kind of what we just walked through. And then when we're looking at our antacids can change the pH in our belly, so therefore it can alter how I'm going to absorb my medication. So that can decrease the efficacy of my dabigatran. So that's why I'm trying to take it 2 hours prior to me taking my antacid. Okay, so my dabigatran goes first, and then I wait 2 hours, and then I can take my antacid. So that way it starts to break down, and I get the effects of my dabigatran over my antacid. Okay. Adverse effects, same things that we talked about before. Big thing that I want to point out here is that we also have our antidote, which is our idarucizumab. And we'll look at that on the next slide, and that'll be the last one that we'll look at today. Monitoring, I don't need to monitor, okay? Make sure that you're just watching out for your patient. If they're not bleeding, same things that we talked about. Contraindication is going to be your patient who has a mechanical heart valve, okay? Mechanical heart valve, I'm worried about it. Looking at your ketoconazole and any of your other inhibitors, because remember that was listed as one of our P-glycoprotein inhibitors. I'm contraindicated using it there. My pregnancy, I don't have enough data to tell you which way you should go. So when I don't have enough data, I avoid it. And then looking at your warfarin to dabigatran, just understand that you need to, that you can change from warfarin to dabigatran. Again, don't need you to remember that cutoff. Just know that you can switch them. And then looking at your stability, when we give this, you see that it comes in like a blister pack. It should remain in the blister pack. This is important for your people who do those pill, their pill organizers. Tell them they can rip off that blister pack and put it in that day, but not to poke out the medication from its package, okay? If that does happen for whatever reason, you have 4 months to use it, but we typically try to make them keep it in that blister pack so that they're not they don't lose potency and decrease the efficacy. What other drug did we talk about that when I open it, it can decrease the efficacy of it and the potency? All right. And then we'll finish this and then we'll stop here. So looking at our dabigatran renal dosing, we talked about this. So when I'm looking at this, I'm worried and I start to change my dose when my creatinine clearance hits less than 30. Okay? So when I'm looking at less than 30, I'm like, okay, I need to watch out. I may need to have a dose, change my dose. I don't need you to remember AFib and all the other things. Just once I hit less than 30, I'm starting to monitor for my creatinine clearance. You see that they don't have any dosing recommendations if it's less than 15. So once I drop to 10, or if I'm on dialysis, there's no recommendations that they're going to have when you look in that monograph for us to use it. So we typically will try to switch them to something else because we don't know if it's going to be as effective. So that's why you see that no recommendation. That's essentially what it's telling you. We don't know what to tell that patient and we don't want to take that risk. Our advantages, again, the same things that we kind of talked about: less bleeding risk, not having to monitor it, less side effects. Again, we're just watching out for that P-glycoprotein, those inhibitors or inducers. And then looking at your disadvantages, we see that renal adjustment may need to be made, and that if somebody has very, very poor renal function, I'm not going to use this. So now my warfarin is looking a little bit shinier. Not used for those prosthetic valves, dyspepsia, or like that upset stomach and like feeling gaseous. Twice daily dosing is more inconvenient for some of our patients and they may not remember that. So just understand that like your adherence potentially to this medication, depending on what's going on with your patients, may not be may not make it as nice in the fact that they're losing the monitoring, okay? So look at the underlying issues of your patients and when we're going to use one versus using the other. And that will help us kind of guide where we're going. So on that review sheet, as we're looking at these drugs, you'll see some of this stuff kind of pointed out where you'll see creatinine clearances on there and things like that. That's what I want you to look at. The dosing that's on there, don't worry about that because I'm not going to ask you about any of the dosing for it. Okay. We'll start here tomorrow.